Hey guys, I'm so sorry. I got caught up on something else. So, any questions about the Kahoot question so far? No, ma'am.
I just didn't understand. I think the last one, I mean, I was trying to read it and I guess it went over my head or something.
What was the question?
I don't even remember the last question.
Well, let me go back and look. What was it pertaining to?
Oxygen. That's all I know.
Flow.
I'm telling you, I can't even remember. I don't.
It was the one right before this one?
Uh-huh.
Okay, so what factor will not affect the delivered fraction of inspired oxygen in low flow devices? That question?
Uh-huh.
So, what's the fraction of inspired oxygen?
I don't even know. Maybe that's all supposed to use. I don't even know.
FiO2.
21.
No, so I'm saying
If you were breathing,
that's what your fraction of inspired oxygen means. So
Oh,
basically, what that question is saying is what will not affect the FiO2 delivered when you're dealing with a low flow device. Does that make sense?
Mm-hmm. I guess. I don't even know.
Do you want to go over it or not?
Yes.
Okay.
Because I'm like still not getting it.
Okay, so what factor will not affect the FiO2 in a low flow device? That's what the question is asking.
Yeah.
Is it computing a little bit better now?
No. I'm not even, I guess my brain is not even kind of getting it. Like what won't affect it?
Right. So there are factors that affect how much oxygen that your nasal cannula, your simple mask, etc., will give to your patient. Right.
Okay.
Okay. So the question was saying what won't affect how much oxygen will actually be delivered to your patient.
I don't remember what the answers were. What won't affect it is
right, and you literally have a slide on in your PowerPoint that says this.
Oh, I'm pretty sure.
Yeah. So the flow of the oxygen through the device. So, for example, if I have a nasal cannula, if I put it on 6 liters, it's going to give more oxygen than it would if I put it on 2 liters.
Exactly.
Right. So the flow of the oxygen through the device, the patient's respiratory rate. If the patient breathes a slower rate, then that reservoir is going to have more time to fill. The patient's going to get more oxygen than if they breathe fast.
Okay.
Okay. And also the patient's tidal volume. So if they take smaller breaths, that's going to give them more oxygen than it would if they breathe bigger breaths. So all those are the factors that influence or that affect how much oxygen this low flow device gives your patient. Does that make sense?
Yes. Okay. But those are factors.
Those are the factors. So the fact, what does not, the other option was a decreased oxygen content in the blood. So what your patient already has in their blood has nothing to do with what that device is capable of doing.
Okay.
Okay.
Yes.
All right. The break was to like get the brain right.
I guess it's been the opposite.
Right. What did you do?
I don't know. I had a bowl of cereal.
Well, don't that kind anymore. And then, so to the current question, how is liter flow, let's just say, determined on a partial rebreathing or non-rebreather mask? And of course, you want to start at 8 to 10 liters, but you want to make sure that the flow is adequate so that that reservoir bag doesn't completely collapse when your patient inhales. Okay, so Taylor's keeping her lead. What is the primary indication for oxygen therapy? Very good. And then, of course, it's hypoxemia. Hypoxemia is, by definition, what?
Low oxygen in the blood.
Right, low oxygen in the arterial blood. How do we fix that? Give the patient oxygen. Okay, so what is defined as an O2 delivery system that provides all of the patient's inspiratory flow or all of the total inspiratory flow? Good. That would be a high flow delivery system. Remember, a high flow delivery system is going to provide a specific FiO2, specific amount of oxygen, and also it's going to provide all of the patient's inspiratory flow demands, all their inspiratory needs. And of course, we have to do some math to make sure it's going to do that. How do you figure out the patient's inspiratory flow demands?
Right to respond.
No, ma'am.
I'm telling you, I don't know what happened with the cereal.
No more cereal for you, ma'am. So remember, that's 3 times your patient's minute ventilation. That's your patient's inspiratory flow or inspiratory demand. So how do you calculate minute ventilation?
Tidal volume minus your tidal volume minus your dead space.
Tidal volume times the respiratory rate.
There you go. Tidal volume times respiratory rate is your minute ventilation. Okay, and then of course you would take that value multiplied by 3. That's your patient's inspiratory demand. Okay, how would you figure out how much flow the device is capable of giving? Bring back good memories of a different box.
Is that that's the box where we subtract diagonally, and then you get the ratio, and then
The magic
Yeah.
box.
you go from there.
The magic box. Oh, I forgot y'all can't see each other. It was like, cause you subtract, so that's why I did the robot arms. Yes. So you subtract this your magic box. So she's exactly right. You subtract diagonally, and that gives you what?
Ratio.
The ratio. So the air to oxygen ratio, you add that together, multiply it by the flow, and that gives you the device's total output. Okay, so you have an example on your math sheet that I sent you yesterday too. So that can be some practice to go back and do. Okay, any questions? All right, bringing back good memories, all these boxes and maths. Good times. Maybe it's moving on up in the world. So a patient's VE is 9 LPM, but increases to 15 LPM. What oxygen delivery device would be best to deliver 30% FiO2? Good job. So that would be a 30% venturi mass. So what is going on here? The patient's minute ventilation jumped from 9 liters per minute to 15 liters per minute, which means that they have a variable minute ventilation. They don't have a consistent ventilatory pattern. So of course, that tells us that a high flow device would be most appropriate. And of course, we know that high flow devices can provide a specific FiO2. We want the patient on 30% FiO2. So a venturi mask is high flow, provides that 30% FiO2. So that's the perfect device for this particular patient. Any questions about that? Okay. Yep, that's a good spot. A newborn's AVG reveals a P-little-a-O2 of 90 millimeters of mercury. What would be the associated risk for this patient? Yeah, that would be retinopathy of prematurity, or ROP. And of course, premature or low birth weight infants are the patient population who's at risk of developing that. Which of the following side effects of O2 therapy are COPD patients with hypercapnia at risk of? Good. That would be oxygen-induced hypoventilation because, of course, these patients are using those peripheral chemoreceptors, which cause that hypoxemic or that hypoxic drive to breathe. We give them too much oxygen. We make their P little AO2 rise above 60. We knock out their hypoxic drive and cause O2-induced hypoventilation. Any questions about that? So a patient has been on a non-rebreathing mask for 4 days and has bilateral atelectasis on CXR. Why? Good, that's because of absorption atelectasis. What is CXR?
Chest X-ray ready?
Chest X-ray.
Chest X-ray. What happens with absorption atelectasis?
You'll see.
You are now unmuted.
Whiteout.
What happened, like on a chest X-ray?
You know, what causes the absorption atelectasis to occur?
If they're O2 inside the mask,
It's fluid in the lung.
the non-rebreather mask, no?
No, it's
Like the non-rebreather itself
Well, what about the non-rebreather?
for so long. Just having it on so long, it's not. I don't know, maybe not.
So how much oxygen do non-rebreathers provide typically?
I don't know. Is that high flow? That's high. No, that's not high flow. Yeah, because you're not rebreathing in the air, so it's giving me too much oxygen.
So what FiO2 does a non-rebreather typically provide?
100%.
Yeah, so about 100%. We know that if we have patients on 50% or higher for 24 hours or longer, we put them at risk of this oxygen toxicity. But the original question was what causes absorption atelectasis? So of course, high oxygen, long time, but the nitrogen gets washed out of the alveoli, right? Then an obstruction comes and kind of blocks the entrance to the alveoli, which means that it collapses, okay? So that's what happens. That's the series of events that leads to a person developing absorption atelectasis. Why do they develop? What puts them at risk of developing that? Putting them on a lot of oxygen for a long time, okay? So you see the difference between kind of all those questions that could be asked surrounding absorption atelectasis. Does that make sense?
Mm-hmm.
So you could ask what puts a patient at risk, what happens that causes it, and then also you could ask, like, how does it manifest? What are the clinical signs and symptoms? And of course, that would be white on a chest X-ray, chest pain, stuff like that. Okay. Any questions? Still keeping it lead. All right, so specific clinical objectives of oxygen therapy include which of the following? Right, good. So this would be, so basically what this question is asking are what are your goals in giving oxygen therapy? So of course you want to decrease the symptoms caused by chronic hypoxemia. You want to decrease the workload of the heart and lungs, and you want to decrease or correct the documented arterial hypoxemia. Can you use oxygen therapy for an acute hypoxemia?
Yes.
Yeah. So it doesn't matter if it's acute or chronic, it's still hypoxemia, right? What's the best way to fix hypoxemia? Usually it's to start off by giving the patient oxygen. What is it called if the patient is hypoxemic, you give them oxygen, they don't respond? What's going on with them?
Is that no? That wouldn't be. Would that be the carbon monoxide poisoning?
Mm-mm.
No.
They're shunting.
They're shunting.
Okay.
Right. So remember we said that shunting is perfusion in excess of ventilation. Something is stopping the ventilation, right? So either the alveoli is closed, it's full of snot, it's full of fluid, something like that. So if that's the case, it doesn't matter how much more oxygen I give you, that oxygen is still not going to pass through that alveoli to get to the arterial blood. Does that make sense?
Yes.
Okay. So what is it called when you give a patient oxygen and we know that it's called shunting, but that term where you give a patient oxygen, they're still hypoxemic. They have what? They have refractory hypoxemia. That's how you know that they're shunting. Mm-hmm. Typically, if it's just a regular old VQ mismatch, you give a patient oxygen, it fixes it. We know that they're shunting because you give the patient oxygen, nothing happens. They're still just as hypoxemic as they were before. Sure, guys. Okay, any questions about that? All right. Okay, what would you do if you received an order for a simple mask and the doctor wants you to run it at 3 liters per minute? Okay, good. You would call the order to clarify. Why do you need to call the order to clarify? What's the problem? Just do it. Right?
Because you can put it on nasal cannula.
Is that what the doctor ordered?
Hey, got me something to eat.
So what's the minimum flow that you need for a simple mask?
Is that a 4 or above?
5 liters per minute, so you can wash out the CO2 that your patient is breathing into that mask. Ringing a bell?
Yes.
Mm-hmm. Yes.
Good. And you can't just switch it to a nasal cannula because that's not what the doctor ordered. So if the doctor specifically ordered a simple mask, you can't just take it upon yourself to say, well, I'm going to switch the device. That's not up to you.
Oh,
Okay. Okay, RLP is a potentially serious management problem, mainly in the care of whom? Good. So that would be premature or low birth weight infants.
You are now muted.
To minimize the risk of RLP, the American Academy of Pediatrics recommends keeping the PaO2 below what level? Good job. That would be below 80 millimeters of mercury. Who do you want to keep the PaO2 below 60 for? What patient population?
COPD patients.
Right. So those CO2, not just COPDers, more, a lot of COPDers, but anybody who's a CO2 retainer and who's using those peripheral chemoreceptors. Yeah, good. Don't leave out your OSA folks. So which of the following statements is false about low flow oxygen delivery devices? All right. So what's false is that the greater the patient's inspiratory flow rate, the greater the FiO2. Remember, the more air that they're breathing in, the faster their inspiratory flow rate, the more room air they're entraining, which is going to dilute and decrease your FiO2. Does that make sense? Okay, so it is true that all of your low flow devices provide variable O2 concentrations. We can't measure the low flow device. We don't know what specific FiO2 is providing. It is true that the O2 is diluted with room air, okay, because your patient is not getting all of their inspiratory flow from that device. Okay, any questions about this one? Apparently it was a little tricky. So anybody not understand why the answer is the one in red? Okay, and did some people get kicked out of the game?
No, I think I just ran out of time. I don't know. I spaced out.
Yeah, I ran out of time trying to.
Okay, I just wanted to make sure it's not getting me off. So low flow O2 delivery systems used in respiratory care include all of the following except okay, and that's going to be your air entrainment mask or your AEM, because that is a high flow device. So your low flow devices are your nasal cannula, your O2 catheter, your transtracheal catheter, but your air entrainment mask is basically your Venturi mask or your Venti mask, which again is high flow. So make sure that if you have to know your devices, okay? As an RT, as a clinician, you must know what your options are for delivering oxygen to a patient. And Nikki's coming for y'all. Which of the following is considered an advantage of the transtracheal catheter? Good. It requires less O2 flow than a nasal cannula. It's going directly into the trachea. It provides a larger reservoir. So it is invasive because it's going into the patient's body, but we usually don't consider things being invasive an advantage, right? Because you want me to stick that thing in your nose or in your trachea, Probably not. So we usually don't consider anything being invasive as a good thing or as an advantage. Because with things being invasive comes the risk of infection, comes the risk of complications as well in most cases. Okay, AJ's done for y'all spot. A patient is on a nasal cannula at 5 liters per minute. Approximately what FiO2 is the patient receiving? Good. So what's your formula?
Was it 4 times the flow plus 20?
Yep, 4 times your liter flow plus 20. So 4 times 5 is 20, plus 20 is 40. So don't forget that little nugget. It's a little formula, but it's an important one. Okay, and last one, what is the minimum flow setting for a simple mask applied to an adult? Like a freebie. Yay! So of course that's 5 liters per minute. Why do we have to set the flow at least 5 liters per minute?
Because there's I don't want to use the word contaminated, but contaminated with room air.
No.
Because even though it has a larger reservoir, it's a lot more mixed air and a lot more CO2.
So it's not about the mixed air, it's not about the room air, it's about the CO2, right? Because if you are wearing a mask and there's not enough flow coming into that mask to wash out what you're breathing out, the patient's going to start to rebreathe their own carbon dioxide that they just exhale, okay? So that's why you need the flow. That flow is coming from your flow meter. It's going to allow a constant flow of air in that mask as opposed to that old stale air just sitting there in that mask, which your patient is going to rebreathe, and that's going to cause their CO2 levels to increase. So that's why you need adequate flow, okay? Similar. Good job, AJ. Good job, Amanda. Ooh, a 19 out of 20. Good job, Taylor. Good job, Flo and Nikki. Any questions about medical gas? Speak now or forever hold your peace.
I just got to go back over these notes. So.
All right. So now everybody's second favorite, farm. Hey. This should be nice and fresh in your brain. There should be just no reason that, we're not getting 18, 19 out of 20.